I am from Wabigoon Lake Ojibwe Nation in Treaty Number 3. I started at Lakehead in 2014 from the the BSCN program, and I worked as an RN in Northern Fly-in communities for the last few years. I went on to study the Master of Public Health program with specialization with Northern and Indigenous Health a few years ago, and I am a recent graduate of the Primary Healthcare Nurse Practitioner program. A lot of First Nations people in my community didn't have access to adequate healthcare. And so from very early on, I decided that I wanted to be a part of the healthcare system and make changes and provide care directly for people like myself. A lot of our communities don't have running water or clean drinking water. We don't have adequate access to healthcare. So people who require a higher level of care are flown from planes down to larger centers. A lot of those factors have influenced where I have seen myself advocating and fitting in the healthcare roles, especially in women's health and women's justice. Throughout my whole nursing career, even in undergrad, I wanted to go to the nursing stations in the north. I just had this calling. It's I want to go. I see this stuff happening. It's affecting people who I know personally and how I've grown up, and I just want to go. My first community that I had an opportunity to be a part of and work in was Poplar Hill. And I owe everything to that community. That's where I learned everything. And I was very close with the health directors and chief and council, as well as the nurses. And from there, I went to a drive-in community outside of Kenora, White Dog First Nation or Wapsimung. And then I ended up in Pikangikum, where I have been for the last 3 years. For me to get to work, I drive from Wabigoon. It's about roughly an hour to get to Sulakau, and then from Sulakau, it's about a 45-minute, depending on weather, 45-minute an hour flight from Sulakau to Pikangikum or Poplar Hill. They're right across from each other. It's only accessible by plane or winter road, so you're either flying or taking the ice road. I work on rotation like most of us do, so we can work two weeks in the community and then we're out for 2 weeks and they fly us home. So nursing stations were created by the federal government to provide healthcare services to First Nations people living on reserve. They are structures that have been built for primary care. They were never meant to be hospitals or provide the acuity of care that we now provide in nursing stations. So, for example, nursing stations are often only staffed by registered nurses or RNs. So we rely heavily on our own assessment skills as nurses, and we are calling doctors on the phone to ask for further orders, to arrange for medevacs to come and medically evacuate unstable, acute, emergent, or just patients who need a higher level of care to larger tertiary centers. So I had just started in the north and decided I wanted to go back to school. So I did do the Master of Public Health program, and I chose the specialty of Northern and Indigenous Health. I felt that it had more courses related to social determinants of health and health inequities specific to being remote, isolated geographically, and northern. And I felt that there was a lot of need in advocacy, so that kind of drew me to that stream. So I did a practicum for the Master of Public Health program in Yellowknife, Northwest Territories, with the Northern Birthwork Collective. So that was a very unique and amazing experience. They focused on birth work and with birth justice and reproductive justice for all birthing people. So a lot of my focus as an RN and my time working as an RN and doing the Master of Public Health program at the same time, I was very focused in the prenatal program in Pikangikum, where I worked with about 100 prenatal patients a year. But during my time in Yellowknife, their obstetrical unit was being closed. So it forced all birthing people or pregnant people to be evacuated to mostly Edmonton for the duration of basically their third trimester, the birth and delivery of their child, and then return to community. So this caused a lot of ripples because historically, First Nations women living in Northern Indigenous communities have always been evacuated for birth since contact. So when I went to Yellowknife, this was happening, but it not only affected the pregnant people from Nunavut and Northwest Territories and the First Nations communities, but it affected non-Indigenous people as well. And so when this happened, it created a lot of media. I guess a lot of people became very interested in it, started to make media headlines. So a lot of our work at that time was talking about that and how this inequity for First Nations people has always existed, and asking for support for those people being evacuated, bringing back Indigenous midwifery and birthing practices. So those traditions that have been lost because of colonization and the evacuation policy by the federal government, it has caused a lot of these, like the transfer of knowledge to pregnant people and girls. There's a lot of trauma that exists because of the separation and those broken bonds. People were super friendly, and I learned a lot about their culture there because it's very different from what I grew up with. When I went, it was like -50 for the whole few weeks, or I guess many weeks that I was there. So I was bundled, of course, and my Canada Goose jacket and my big scarf, and I had to walk from the apartment I was staying in to my preceptorship. And I remember my eyelashes were like frosty every morning. They didn't stop me from going out and watching the Northern Lights every night. It was beautiful. When I was working as an RN in the Northern communities, we were following what was called clinical practice guidelines. So we would basically be dispensing our own medications for these complex health issues. But I felt like as an RN doing that, I didn't exactly know, like, why am I doing this and why am I prescribing this and why am I dispensing these medications when I don't fully understand like the complexity in that. So that really sparked my interest into the nurse practitioner program. It's allowed me, when I return, to be able to do those things on my own. So do my own diagnostic testing and order through the lab. I can dispense and prescribe my own medications with my own knowledge, skill, and judgment. I think it allows me to provide better care in Northern First Nation communities. So I was actually in Yellowknife when I got an email notification from RNAO asking for RN volunteers who were willing and able to go to Ukraine with the Canadian Medical Assistance Team. I felt a huge calling to go. I just felt like what was happening wasn't okay and applied. I didn't want to be a bystander that just saw it on the news and didn't have any part of it. So we stayed in Poland, and then every day, if it was safe to do so, we traveled across the border and we staffed it was a converted train cart that had been basically like refurbished into a little primary care clinic. So that's where we staffed right at the border on the Ukrainian side. And then we had a mobile clinic that went into Ukraine every day. So there were a few different places that we visited just to provide care. So most of these places that we went were camps or structures basically that were housing internally displaced people or people who'd come from the front lines, or families that didn't want to leave the country or were unable to. So that's where we kind of came in and helped, is those people who didn't have access to healthcare, or they left their medications at home, or they had infections that were treated at the front lines, but now they're infected. So that's kind of where our team came into play there, and at the border where people had been waiting for days to get across. So the men weren't allowed to go. There was that they had to stay behind in their country, and that was the laws at that time. So it was just women and children that were crossing. So a lot of what we saw was people bringing their families and loading up their children and partners, wives, into vehicles. Sometimes they didn't even know the driver, and sometimes they were just squeezing into other people's vehicles just to get across the border so that the men could go to the front lines. So there were a lot of goodbyes at our crossing. A lot of the needs that we were seeing were mental health or PTSD related. A lot of people who couldn't sleep, insomnia, like children bedwetting that had never experienced that before. Just a lot of like sadness. We saw like a lot of like depression, anxiety, post-traumatic stress disorders, a lot of like grief. I would say were like the major things that we did see, along with just like a lack of chronic care, because people had left their homes. So in the midst of a war, people left behind their medications. They did not do follow-up appointments with their primary care providers. Like they did not have their blood work done. They've had these, like, for example, uncontrolled blood pressure. So now they're coming across the border when they've traveled for days or have been in internally displaced people's camps and haven't had any medications. I think that the support that we had there and the team that I had been deployed with, I think we're forever bonded to each other, and we've become like a family, and we're still in contact today with our teams. I think that, what we saw, a lot of people thought we would never see in our lifetime. I learned a lot, and I take a lot away from that. And I still am rostered with the Canadian Medical Assistance Team.